Yeah.
It's off.
Gel.
Like Chris Conner.
It's just like right here, right at the edge of where your shirt is. You clean me up, okay. That's right. Here. That's just trigger your hand.
I really hope this breakfast.
So here you go. Here, what's so you see the flexor tendons, right? So what's right next to them? Those type of colors. Right.
Yeah.
Well, you're freezing. Right? Interossei is the bone, right? So here's your metacarpal, right? So here's your interossei. What muscles are these? They have home independence. So here, right here, yeah, here is your lumbar. What's your on it's there, right? Easier, yeah. So
We started with fluids, but then,
So she was really
was that, well, that's, I mean, that's part of it, I'm like, I don't know why she was like, so she also had that, like, to that, like, ridiculous stat lab, like, the last gas was already there, so, I haven't today's she's awake the whole time, I talked to her. So right now, she's on the way down to see today, and then they're gonna transfer her straight to medicine.
okay. I'm gonna ask you about this like probably one more time because I feel like that's a lot going on. I have no idea. Yeah, because she wasn't on any.
She's like,
To do either.
Yeah.
See if I can. You just so Dr. Alsh really called me. He wants to watch.
yeah, so you can get into whatever you need to.
So I can open my email. Okay.
Anything on the
They want to put a little body around. So then you direct that. Direct that. Comes off the so here's acid. They want to put
James, if you're gonna record it, can you like actually record it so I can show my parents?
Yeah.
That'd be so cool. Thank you.
No, it's it'll be on YouTube.
Thank you.
Yeah.
Is it like a live thing, or will my parents be able to see it later?
I mean,
The
it can
YouTube
be
part.
live if they-
No, but it'll be. They can see it later.
Yeah, it's recorded.
Okay.
I can
Since they have
download
no.
the file if you need me to, but otherwise, like I said, it'll just be a link on YouTube,
That's awesome.
part of the page and all that.
Because they have no idea what I've been doing for the last like 2 weeks.
Just like.
Control C.
I will be there.
How do I close this?
They're pretty like.
Thank you so much, Randy. Ah,
You would have made it. All YouTube would come. You know, oh, it's Tony's fault. I guess.
F-tube. Oh, what was it on?
That's a well.
School tube, okay.
Just get them.
I hate that. It was like. When did take that?
Yeah. Yeah.
I can see that. Sexy mommy. Can't help it. That's a new one. Don't you start Workup? Not coming back. Yeah. What is it? Doesn't it share? Yeah.
So jealous.
Down your road. Coming up with you. What time you get out? Oh, this must be Randy, so whatever. Randy, is that you?
No, that was me, Cora.
Oh, is that Jade? Oh, yeah. I was excited. Yeah. What time did you get out yesterday? Did you see her new picture? Every day. Did you get to see the whole? Look at the video. Yesterday. Can you believe it, James? So mean, what are you doing?
Hey, Matt.
How are you doing? Yeah, I'm Andrew again. I know. It's been I said I worked with you a year ago. When you were doing the same thing. Like, how's
So
it
it's
going?
your second ER rotation.
Yeah.
Wow.
Yeah. I'm excited. Hey, how you doing? Yeah, I said.
Shut up. Did you see the baby picture? You know what happened?
I know, last time I saw you.
Pregnant.
Wow.
Time go by quick, right? right?
Oh, my.
Is she my mirror image?
Yes.
And then,
Really?
I won't ask
Worst case scenario, we gotta find it.
This is the last last 3 years.
Sure, it's really like this.
Oh,
All right, guys, have a seat.
I need like some lights.
Oh, no, you're fine. Yeah, I'll just turn them off.
I have notes for myself.
Good. Okay, guys, so Dr. Rose Alapat is going to give her grand rounds here, the final resident grand rounds of the year. So it's on innervated bone. And
many other topics under that category. So, Rose, do you have any disclosures?
No.
Okay.
So, hi, I'm Rose Alapat, and my topic today is neuro-osseous innervation. And there is a reason why I chose this topic. You know, as physiatrists, we do see patients with various diseases that end up affecting innervation. And whether it's a spinal cord injury or a stroke or the loss of peripheral innervation in a diabetic, when a disease process affects innervation and it also results in bone losing innervation, and there can be profound pathological impacts. So we need to further understand what is happening to our patients, because I think that we will be the ones treating neuro-osseous pathologies in the future. In my first year at Mons, I've already seen this. I've seen it in a spinal cord injury patient who developed a fracture during a routine transfer. It was very low impact. And I think we've all seen patients with either Charcot neuroarthropathy or who came onto the amputation service because they had Charcot neuroarthropathy. And I think it's really important that we actively start thinking about neuro-osseous innervation, especially because this is something that is playing a key role in the pathology that we see. So about 200 years ago, Jean-Georges Lobsine, a French pathologist, noticed that some bones were more porous than others. And he came up with the creative name of porous bone, or osteoporosis. About 60 years later, Julius Wolff, a German surgeon, developed Wolff's law, which basically states that there's a mathematical relationship between the strain that a bone is put under and the increase in bone density that it undergoes. And that's given rise to the modern idea of functional bone adaptation, which basically states that, you know, when bone is subject to local strain, it locally remodels in order to meet the demand of that strain. So you can see, like, bone has an optimal strain level, but there's an increase in that strain, there's increased bone deposition, which makes it come back to that optimal strain level. But on the other hand, if there's not much strain on the bone, there isn't that, I guess, input to build up and bulk up, so bone eventually loses density. But there's a homeostasis that's involved. So essentially that local bone cells sense mechanical strain and adapt accordingly. So in the 1930s, Albright Fuller noted that postmenopausal women were very much prone to osteoporosis, and he realized that there was a link between estrogen deficiency and postmenopausal osteoporosis. He later on went on to work up other, like, vitamin D and other nutritional aspects that were influencing osteoporosis. And, you know, these are probably things that you talk to your moms about, you know, like stop smoking, take calcium, get your vitamin D, do weight-bearing exercises, which is actually based on the functional model of bone adaptation to strain. There are other things like reduce alcohol and medication side effect. But something's missing, and that is neurogenic osteoporosis. So peripheral innervation does play a role. So in 1545, Charles Essien made the first the earliest known documentation showing nerves entering bone. And then 4 centuries later, science published this picture, which was taken with an electron microscope that shows nerve fibers innervating osteocytes in cortical bone. And a few years later, they eventually found, like, both myelinated and unmyelinated nerve fibers innervating bone. And from that point on, there's been a steady trickle of research in this field. So now on to the research studies. So Dr. Ding carried out a series of experiments with capsaicin. And capsaicin is really useful to study sensory nerves because it's only neurotoxic to sensory nerves. Capsaicin exerts its neurotoxic effect by acting on the vanilloid 1 receptor, which is only there in unmyelinated and small diameter sensory neurons. So he basically gave rats capsaicin to try to knock out the sensory nervous system as much as he could. And what he found is that those rats developed osteoporosis or lost trabecular bone density. And you can see in this graph that the more capsaicin that the mice receive, the more osteoclasts, which are the cells that resorb the bone, were there per like square unit of area. But you're probably thinking, okay, if you inject a mouse with capsaicin and you try to destroy its, peripheral sensory system, like maybe the rat's not going to be as ambulatory as before, right? The mouse or rat can't feel where it's going and it's falling and stumbling. Maybe there's some element of disuse osteoporosis. So a second doctor, Dr. Offley, did a very meticulous study to try to control for that. So she measured three measures of rat activity. One is grid crossing frequency. One was hind limb weight bearing, and the other one was the mass of the hind limb muscles. And the assumption was the last one is if the rat's not moving around, that those aren't going to be as bulked up. And what she found is there was no significant difference in the activity of the rodents in the capsaicin group or the control group. They moved around the same. And you can see in her results that when the rodents were given capsaicin, which is the black one, they had significantly reduced bone density. And these two are measures of bone strength. And you can see again, in the capsaicin groups, they're significantly reduced. And then here showing that over time, there was significant loss in bone mineral density in 2 different locations of the capsaicin-treated rodents. Sorry. Okay. So another interesting thing that she found is that when she looked at nerve biopsies, that there was a significant reduction in the number of sensory nerve fibers. We expect that. That's why we use capsaicin. And she also found a significant reduction in the amount of substance P, which is actually being studied for its role in bone pain, especially in cancer, and CGRP, calcitonin gene-related protein, that we are going to talk about over and over and over again. So, as an aside, this is a picture of a girl with Riley-Day syndrome. And it's one of those rare autosomal recessive diseases. But it's interesting from the perspective of my presentation because these patients feel no or very little pain. They also have difficulty with temperature sensation. And they also develop early osteoporosis and have an increased risk for fracture. So I'm kind of wondering, and some of the papers have wondered, if maybe, there's a relationship between the loss of peripheral sensory innervation and the increased fragility of their bones. And if so, some of the therapeutic options that we talk about might apply to these patients. So, I think I'm on my next section of notes. Yes, I am. So, bone remodeling. Dr. Sample designed an interesting set of experiments to study this further. And in the first experiment, Dr. Sample essentially applied pressure to the right ulna of rats. And after the right ulna strain was applied, there was increased bone density in that area. And that's expected based on the model we've been talking about. But what was really surprising is that when she applied the right ulnar strain and checked the left ulna, there was increased periosteal bone deposition. And there was no way for her to, and I guess there's no way for that current model that we were talking about to explain that. Because if you expect right ulnar strain to have any impact, it would be local. This is a bone on the opposite side of the body getting more bone density. So clearly our old model doesn't work. I want to make sure I've said everything I wanted to say. Okay, so they hypothesized that, you know, there are only two mechanisms for this bone communication, that one bone can communicate with the other bone. And it's either going to be hormonal, that when the bone is exposed to strain, it releases some kind of factor into the blood, and the bone on the other side senses it. Or there could be some kind of neural neural connector. So she did a second set of experiments in which the rats were given a right brachial plexus block before undergoing the strain. And what she found was that it completely blocked any left ulnar gain, and any increase in left ulnar bone density. So at least I take that to mean that the connector was the nervous system to a great degree. But this is where it got weird. Not only did it completely block the distant bone density increase, but it significantly reduced the local bone density increase. So it looks like the nervous system also plays a significant role in local bone remodeling. So then Dr. Wu performed an interesting set of studies to try to tease out the mechanism involved with this. And scientists use this pseudorabies virus essentially to trace fine neural networks. What they do is they infect, one of the neurons, and this virus is only synaptically transmitted. So you're not going to get just a gross general infection of all the neurons in the area. Only nerves that are synaptically connected are going to get infected. And essentially what Dr. Wu's team did is they took rats, they applied the right ulnar, they injected the control group and the regular group with the pseudorabies virus right over their right ulnar periosteum. And then they applied the strain to the experiment group and a sham strain to the control group. And what they found is that in the control groups, all the rats showed infected neurons in the distal extremities of all four limbs. This is really interesting because it's a network connecting the bones is there in all four limbs. And then when you look at the rats that actually experience strain, you can see that there's a significant increase in the number of affected neurons. And the authors hypothesized that this was because there was an increase in dendritic growth. And that, let me go to the next slide. And that this might be some kind of form of adaptation for that local strain model we were talking about that applied to distal bones. So what did we learn? One, that bones of all four extremities are connected by a neural network. Two, that bone strain strengthens this connection throughout the body. And three, that there seems to be some kind of neural memory for strain. And this neural memory might serve to optimize the skeleton for habitually encountered strains. And if so, this might be an important factor in protecting us against fractures. So, before osseous functional adaptation was thought to be carried out by local bone cells in response to local strain. However, these studies show that the nervous system also plays an important role in the bone's functional adaptation response at both the local and distal sites. Okay, so how do nerves talk to bone? Bones are innervated by sensory and sympathetic fibers. We talked about the sensory fibers with, the CGRP and the capsaicin studies. We're going to talk about them again when we talk about Charcot neuroarthropathy and diabetics. The bone is also innervated by sympathetic fibers, and I'll talk about that when I talk about why it is that it seems that frail, thin women are the ones who get osteoporosis and break their hips. Now, of course, there's not like an actual synapse. We think the mechanism of I guess we think the way that nerves essentially talk to bones is by like diffuse release of neuropeptides. So glutamate is an excitatory neurotransmitter. It's found in receptors for it are found in osteocytes, osteoblasts, and osteoclasts. And there are studies showing decreased markers of osteoblasts and osteoclast activity when exposed to various NMDA receptor antagonists. So now to go back to an earlier slide, we talked about the experiments that try to study the peripheral nervous system and its role. Dr. Offley had noticed that sharp decrease in CGRP, which is calcitonin gene-related protein. And it's basically related to the calcitonin hormone. So calcitonin is used to decrease calcium serum levels in the blood, and the two mechanisms that we're interested in is that it increases osteoblast activity and decreases osteoclast activity. And let's see, in the next few studies, we'll show how calcitonin gene-related protein seems to have similar effects. So Dr. Valentin removed the ovaries of mice to basically simulate postmenopausal osteoporosis. And Dr. Valentin found that the mice that got CGRP injections had increased bone density. I'm sorry, that they lost less bone density than the other postmenopausal controls. So it seems to have a protective factor. And then these results were further supported by another study by Dr. Balika. So Dr. Balika said that, okay, if you inject CGRP like into the blood or into an animal that's really systemic, what if it's local? Because we want to study bones specifically. So she designed a study where she inserted a human CGRP copy, like right behind the osteocalcin gene, which is a gene that's only expressed by osteoblasts, so that the human CGRP would only be expressed inside the osteoblasts. And she found that that also seemed to increase bone density. So now I'm going to go on a slight tangent, and even though I haven't done my traumatic brain injury rotation while I was reading up on this subject, apparently some clinicians have noticed that patients who've had a traumatic brain injury, and I guess a fracture along with it, seem to have faster healing fractures. And in that line of research, they've also noted that patients with traumatic brain injury also have higher levels of CGRP in their serum. So one group decided to study this in rodents by measuring the CGRP level in the controls, in rodents that were given a fracture, in rodents that were given a traumatic brain injury, and the unlucky ones who were given both. And what they found out is obviously the control group had a normal CGRP. The fracture group, as expected, had a higher amount of CGRP. Before, CGRP is related to fracture healing. That the TBI group had an increased amount of RP, which we expect going into the study, and that the mice or rats, I forget which one, that had both the TBI and the fracture had a much higher amount of CGRP in their serum. And they speculate that this high amount of CGRP explains the finding that you heal from fractures faster. But obviously, there are factors being released during a traumatic brain injury that might also be helping in this. So, in med school, I'm sure you've been told, like, you know, it's a thin, frail woman for, you know, these are the ones who are going to fall and break their hips. So recently there's been a lot of research into leptin. Leptin comes from the word leptos, which means thin. It's released by adipocytes, hunger, and it also induces osteoporosis. And I'm just going to take another tangent really quickly. Interesting because there are higher levels noted in anorexics who also don't have much hunger and are prone to stress fractures. Okay, so there are two major mouse models that used to study leptin in general. And one is the leptin deficient mouse, which has strong bones and is a little overweight. And the other one is the leptin receptor deficient mouse, which also has strong bones, is a little overweight. So what happens when mice are genetically modified to produce leptin only in their osteoblasts? Nothing happens. Leptin does not induce osteoporosis when it's put within the osteoblast. So that suggests that there must be some connecting factor between leptin and the bones that's causing osteoporosis. And we think that's the sympathetic nervous system. So we said before that we know that there is sympathetic innervation of bone and that osteoblasts have beta-2 adrenergic receptors. So this is a proposed mechanism that, you know, adipocytes release leptin, which acts on the hypothalamus, that uses a sympathetic relay to affect the osteoblast to release rank L, which increases osteoclast differentiation. And of course, real life is never like super simple. There's, you know, other complicated things going on, but I would like, for the purposes of this presentation, to focus on the neural things. So there were a bunch of rodent studies again. They showed that wild-type mice, when they got a leptin injection to their brain, had decreased bone density. But based on what I said, what about mice that don't have a functioning sympathetic nervous system? So there's a mouse for that. The DBH knockout mouse is a dopamine beta hydroxylase is an enzyme that's required to convert dopamine into epinephrine and norepinephrine. And these mice are used to study the sympathetic nervous system. It's known that at baseline they have increased trabecular bone density. So when these mice got an intraventricular leptin injection, they did not lose bone, which makes sense because we knocked out the sympathetic relay. So again, the effects of leptin on bone do appear to be mediated by the sympathetic nervous system. So we have many ways of manipulating the beta adrenergic system. So clearly someone's going to study this pharmacologically. So isoproterenol is a beta agonist, and when given to wild-type mice, it does induce trabecular bone loss. That makes sense. Propranolol, which is a non-specific beta blocker, increases bone density in wild-type mice. And that raises interesting questions about whether beta blockers might be a potential therapeutic for not only neurogenic osteoporosis, but osteoporosis in general. So there have been other interesting studies. One showed that beta-2 receptor knockout mice have higher trabecular bone densities, one showing that beta-2 receptor knockouts lose less bone mass when they lose their ovaries, and one that shows that beta-2 receptor knockouts who get a bone marrow transplant from a wild type develop normal bone density. And that propranolol reduced bone mass loss in rats following gonadectomies, and that propranolol reduced bone mass loss in rats with hind limb unweighting. And this is how they study basically disuse osteoporosis. And since marijuana seems to be like the hot topic today, like I wanted to include it in some way in my presentation. And this was the only reach I could get. So, you know, there are various bone cells that do release endocannabinoids, and they seem to oppose or at least attenuate the effect of the sympathetic nervous system. So how they do that is they act on the CB1 receptor on the sympathetic nerve terminal and inhibit the release of norepinephrine. Osteoblasts, osteocytes, and osteoclasts also have CB2 receptors. So obviously there is a CB2 receptor knockout mouse. And these mice develop increased age-related osteoporosis compared to their wild-type controls. So that is part 1. Part 2 is about Charcot neuroarthropathy and its relation to the peripheral nervous system. Partly because I'm very thirsty and partly because I feel like I need a break. Does anyone have any questions at this time? No? Okay, fine. It's a lot of talking. Okay. So in 1868, Jean-Martin Charcot described Charcot joints in a patient with tabes dorsalis. At that time, tertiary syphilis was the leading cause of Charcot neuroarthropathy. Currently, diabetes is the most common etiology. However, any condition that results in a sensory neuropathy, such as alcoholism, pernicious anemia, polio, cerebral palsy, Charcot-Marie-Tooth disease, syringomyelia, various spinal cord injuries, and leprosy can put a joint at risk. And actually, the first person to document the disease was John Kirsten Mike Mitchell in 1831. So this is, these are the knees of the patient with tabes dorsalis. So studies do suggest that 1 to 7.5% of diabetics will develop Charcot neuroarthropathy. Mean age of presentation is approximately 60 years old. Sex does not appear to be a risk factor. And the majority of patients have been insulin dependent for more than 5 years. Both peripheral neuropathy and intact circulation are required for the development of Charcot neuroarthropathy. And acute Charcot neuroarthropathy is usually unilateral, but 9% of the time they can come in with bilateral Charcot. Some patients might be able to remember like an inciting aggravating factor like a sprain, but many don't. So the affected foot is usually warm. See the number 2 degrees Celsius or greater compared to the corresponding location on the other foot. The dependent rubor observed in Charcots usually resolves when elevated for about 15 minutes. And that can be a helpful, I guess, tool to try to differentiate that from cellulitis or osteomyelitis, which would not resolve with elevation. 75% of patients may complain of pain, but it would be much less than you would expect given how bad their foot looks. The foot is edematous, erythematous, and hyperemic with bounding pulses, although sometimes with the amount of swelling it can be difficult to see or feel. And the bounding pulses observed in Charcot neuroarthropathy are interesting because one of the recent review articles suggests that peripheral arterial disease might be protective. So this might explain why, with so many diabetic patients, that only really a small subset of them seem to be developing this. It might be because peripheral arterial disease does tend to go along with diabetes. So, other things that you should expect in like any diabetic foot, not just Charcot neuroarthropathy, is dyshidrosis, which is the autonomic neuropathies that can lead to like dry feet, which have more cracks, prone to infection. the gross deformities that you might see in some patients with Charcot neuroarthropathy actually don't present in the acute phase. So it's very possible that you might just see what looks like a diabetic foot, which is, due to, decreased, or basically like a collapsed arch due to, weakened muscles. What else? And, because that results in abnormal pressure on the distribution of the diabetic foot, you might see like just some basic signs of deformities. So there are different types of Charcot neuroarthropathy. If you're really interested in it, you can read my paper, but I don't think any of us will ever classify this. So I'll only kind of talk about a couple of things. One, note that, it always seems to be articular to some degree. The other thing is that based on where the disease is affecting the foot, you can have different complications. So this one is a type 1 Charcot neuroarthropathy, which results in the collapse of the midfoot. These patients are prone to chronic ulcers and fixed rocker bottom foot deformities. This is a type 2A, right here, Charcot foot, and these patients are, they have unstable feet that require prolonged periods of immobilization. So when you see a patient with Charcot foot, there's a lot of things that you'll have to consider. One is osteomyelitis, inflammatory arthritis, trauma, cellulitis, DVT, and gout. So basic workup involves CBC with differentials, CRP. However, both the white count and the CRP can be elevated in acute Charcot, even if there isn't an accompanying infection. Uric acid level to rule out gout, Dopplers to rule out a DVT. It's recommended that you get an X-ray, although the bony changes will not be evident in the acute phase, but just rule out fractures or anything else. The one, I guess, image modality that will pick it up very acutely is MRI or bone scan. It'll show some subchondral bone changes. So there isn't like a special intensity that you need to get in order to differentiate between osteomyelitis or active Charcot. Basically, you tell the difference by location. So like before, I told you that in Charcot, it always seems like it's articular surfaces that are most involved. In osteomyelitis, you would expect a slightly different pattern. So management. There's actually a little bit of controversy on this, but for the purposes of this presentation, I'll just go with what's mostly mainstream. So the mainstream management is that you completely offload the affected foot. And the reason why is Charcot's neuroarthropathy has a severe, uncontrolled inflammation that's extremely destructive to the bone. And the goal is to reduce the microtrauma as much as possible during this phase. And this phase can last for 2 to 3 months. Another thing is, this is a total contact cast. It also tends to do a really good job of reducing the edema. And once it does that, it's not really effective, so it has to be replaced weekly. And another good thing about it is that it helps distribute the vertical pressures on the foot more evenly. But after 2 to 3 months, they get transitioned to a less restrictive MAFO or CRO, which is a Charcot restraint orthotic walker. And then eventually you'll transition them to a diabetic foot or some kind of offloading podiatric device. So pathophysiology. So there were 2 leading thoughts on what the pathophysiology of this disease was. One was proposed by Virchow. Okay, seems to be some debate. Virchow, who supported the neurotraumatic hypothesis. And that makes sense. If you think about a diabetic patient who can't really feel anything, they stub their toe, they're not really detecting their joints because they don't feel pain, so they're less inhibited. They may also, be like moving their joints in abnormal ways that would hurt you or me or just not feel right, not notice it. So that's essentially the crux of the neurotraumatic hypothesis. And then there's Charcot's hypothesis, the neurovascular hypothesis, which is that the autonomic dysfunction results in these changes in the flow of blood, which result in hyperemia in some vessels, which does make sense if you think of the bounding pulses I talked about, but then also relative ischemia in like certain other ones, which result in like impaired, like pockets of impaired nutrition and blood flow. So we'll come back to those later. So Sharko inflammation, as I said before, it's a acute burst of extremely destructive inflammation. And research in this area is focused on monocytes and cytokines. So there was an interesting study where someone basically tested for the particular cytokines that are of interest in this area and looked at specific monocyte phenotypes that are being studied. And she took blood from non-diabetic controls, diabetics with non-complicated neuroarthropathy, and patients who were having acute Charko neuroarthropathy at that moment. And the factors and phenotypes we were looking at was normal between the non-diabetic controls and the diabetics with non-complicated neuropathy. Of course, they were significantly higher in the acute Charko patients. So what's interesting is that after the acute episode had resolved, the factors that she was studying normalized in the acute Charko patients. So they took that to mean that it's not that the Charko patients have this inflammatory process going on at a much higher detectable level at all times. They can go back to normal. So what they speculate that is what's going on in Charcos is that some factor that is helpful in reining in this out of control, super intense inflammation is missing. I think based on my presentation, I'm going to say it's a neural factor. So remember this slide where we talked about how peripheral sensory nerves do release CGRP. There are many studies that show that CGRP doesn't seem to reduce, I guess, the production of inflammatory cytokines in monocytes, which is directly related to what I was just talking about. So I guess like right after reading that, the first thing that I wondered is maybe if I give my patients calcitonin, I'd be like the next big thing. Find like a good treatment for Charcot. And someone had already thought about that. So there was a study where patients with acute Charcot neuroarthropathy were given calcitonin, and they did significantly better than those who didn't receive it. But it was a small study, obviously needs bigger trials. So in the end, they were both right. This is a rank ligand hypothesis. And basically, you can see that Charcot was right in that the neuropathy results in a loss of that CGRP, which stops this whole pathway. And that, which I was right because of repetitive trauma does increase the pro-inflammatory cytokines that does initiate this pathway. So thank you for your attention. Does anyone have any questions? Oh, wait. I want to thank Randy for bringing in breakfast and Dr. Alschuler for mentoring me. Oh, and I saw this and it was super cute, so I want to play it. Whoa. Okay, not that. Where's my other window?
Very trippy.
Oh, okay. Well, I had a really cute song, but that's okay.
The Safari X.
The Safari window?
Yeah. Oh, okay.
Okay. So, does anyone have any questions? Oh yeah, the dumb bones. Oh, you can't hear it. That's okay. No questions. I guess I was just so Peter.
Is the theory behind why Sharko disease is more protective for Sharko hypothesis? Is that because they better intensify, or is it just kind of like shooting the blood with the foot?
So they actually, so it involves the idea that for some reason the high flow seems to induce bone resorption. And that's not really explained well. And it's just, I don't think they have too much of a theory on why. It's just that in some studies they seem to be seeing that people with peripheral arterial disease are having it less than they should. Any other questions? Yes.
Do you recommend a bone biopsy for acute Sharko?
Oh, I didn't even. So there are all these things I was going to say that I got so excited about that I forgot to say them. So basically, the problem with Sharko's is you saw like how deformed those feet look, right? So it's very common to have either an osteomyelitis with Sharko's, or sometimes you're just hard to tell apart. So if you can't tell them apart, that's when you get the bone biopsy. Usually, like with imaging and history, and if if you're not seeing a leukocytosis and CRP and the other things that you're looking at, you probably won't have to go to the bone biopsy. I know. Huh. That is really interesting, and I'm not sure. That was like one of the things when I was like kind of wandering for my search I found, and I thought it was super interesting, but I didn't like actually go into that part too much. Yeah. Yeah. It is a trippy world out there. Okay. Okay, well, thank you.
I really like the video.